Head of Child and Youth Mental Health at West Moreton Hospital and Health Service in Queensland, Australia. He strives to achieve an integrated and holistic approach to understand and manage emotional difficulties in children and their families. Please join us in welcoming Arun Pillai. He will be talking to us about psychotropic use in autism, good, bad and ugly.
I just wanted to kind of, before I start, reflect on the hard work and commitment put in by CADRRE and its team in setting this up, organizing this today, and having us all today. Great work. Hats off, team. Now, I just wanted to kind of talk about sort of, we call ourselves God's own country, and whether you believe in it or not, right now the gods are probably not very happy with us. And we are going through kind of a natural calamity that's never been seen before. For the last 3 days, I think around 106 people lost their lives, and thousands are stuck, waiting to be rescued, and hospitals are being evacuated. They've lost power, they've lost oxygen connections, and people who've just had surgeries are being relocated. And while I was in here yesterday, I think I was kind of oblivious of the gravity of what was going on out there. And I talk about that because I think sometimes when we think about treatment options for autism, there may be a parallel there, in the sense that we can get a lot bogged down with interventions, evidence-based, and in that process, sometimes we kind of forget to understand the social system around the child and the family, which actually, if you really think about it, perpetuates and precipitates a lot of challenges that we see in autism. Psychotropic use in autism, I think it's been well researched. There's lots of evidence there. A lot of people have talked about it. I've kind of approached this from a clinician's perspective. So I'm not a psychopharmacologist. I'm not a neuroscientist. I'm a clinician. I'm a child psychiatrist working in a busy child and youth mental health team in one of the western suburbs of Brisbane, which struggles socioeconomically. We have a massive catchment. We've got lots of rural areas with very limited service options. To put that in context, a non-urgent pediatric review can have a wait period of around 12 months. So you really want to see a pediatrician, particularly a developmental pediatrician, it's 12 months. And Child and Youth Mental Health Services, we work, or used to work, with this philosophy that if there's anything developmental, if there's ASD, if there's intellectual disability, anything developmental, it's not mental health. We are not interested in it. That's pediatrics. So where does this families go? They're not real answers unless you can afford private interventions, which can be very expensive. But then you always get this question of, you got this 9-year-old who's been to ED 3 times over the last week, and he needs sedation when he gets to ED. There's been property damage. ED struggle to manage it. I mean, Ipswich ED is not set up for kids, and ED is sort of saying, we need to stop this. And you get this call from emergency physician saying, can you review, can you fix this medication? Can you do something? We want to stop him from coming to ED. And sometimes it's the schools, they would sort of ring saying, we can't tolerate this behavior, it has to stop. And if we don't stop that, we probably will have to look at suspending this child. And suspensions in Australia, and I think, I'm not sure how it works in other areas. In Australia, you get suspended for a couple of days and then it becomes a week, then it can end up with 4 to 6 weeks. So this child is then excluded from schooling. So there is this pressure to kind of do something about medication. And that's when you think about what does the evidence tell us about medication? Does it work? What works? What does not work? And that's the context in which I thought of doing this. This is kind of a brief literature review over the last 20 years. We've done this before, it's multifactorial, neurodevelopmental condition, lifelong implications, begins in early childhood. The focus has been on early intervention and diagnosis based on 2 core domains, so social communication and restricted repetitive behaviors. Increasing globally over the last 50 years, 1 in 160 based on WHO, 1 in 68 based on CDC. I think the more recent numbers are even bigger. There's been various explanations around why is this number going up? What is behind this dramatic increase? And partly it's because of probably broadening of the spectrum, improved clinical direction or detection, and higher awareness within the society about the importance of early diagnosis. But there probably are some controversial ones, like is the funding model or the support system at school promoting a diagnosis? Just again bringing it back to the Australian context, we now got the NDIS, and which is the National Disability Insurance Scheme, and a child with autism level 2 comes under what they call as an A list, which essentially means it's automatic funding. So if you have a diagnosis of level 2 autism, you're likely to get funding, whereas if you just doesn't meet the diagnostic mark of autism but still have got similar disabilities, you probably, there is a possibility that you need more paperwork done. But again, I don't think that explains this increase across the world. But that's being sort of talked about in some of the meetings that I've been to. What are the key issues or challenges that a young person or family face with autism? I feel, one of them is we talked about the social exclusion. The other thing is discrimination. I haven't put any numbers there, and I think somebody was asking about in one of the question and answer sessions the other day. These numbers are from a talk, so I haven't verified with the paper, but apparently 1 in 5 people with autism end up in full-time employment. And out of that, around 43% actually lose their job, and only 10% get supported in their field of work. So really, there is a lack of support around employment and keeping them in employment. And also, around 80% of people with autism get bullied, whether it's at school or at work. So the discrimination, it's there. And then there's the stigma, not only to the child, but also for the family. And that then perpetuates social exclusion. So it's sort of this vicious cycle there. Then you've got the behavioral and emotional difficulties, physical comorbidities, psychiatric comorbidities. So when we have all these issues, when we are thinking about formulating a treatment plan for autism, I think it should include all of these, and biological treatment options may be a part of it. But I think it's very important to put that in context, that psychotropic interventions or biological treatments are going to be part of or one of those many interventions. Again, something we've discussed this before. Etiology of ASD is not completely understood. It's complex and it's heterogeneous. It may be genetics, it may be environmental, maybe a combination. There's neuroinflammation, there's mitochondrial dysfunction, and impaired immune response. They've all been considered as possible etiological factors. Now that heterogeneous etiology in itself can be challenging when you're looking at developing biological molecules with particular targets. So, how do you develop a molecule that then targets these, has got these multiple targets? That's been a big challenge for a long time. And it's clear that no one treatment is going to be effective for all, and no one treatment is going to be effective for the child across the developmental spectrum. So, what's effective for a 6-year-old is going to be different for 11 and 13 and 14. And that's not just psychotropics. I think that's going to be true for any other intervention. Current psychotropics, there is not effective to treat core symptoms of ASD, but psychotropic medications are widely used. 64% of children with ASD are on at least one psychotropic medication, and 35% on polypharmacy. This particular study looked at polypharmacy as 2 or more There are studies which would define polypharmacy as 3 or more, and that then the number then drops down to 15. When we did an audit of our clinic, the number comes up as quite, probably in the low 90s. And that is because I think we are a tertiary child and youth mental health service, and it's a skewed population. So I don't think you can generalize that. But so if it's not effective for core symptoms, why use psychotropics? Even though it does not affect, maybe does not sort of do a lot for the core symptoms, it does alleviate the behavior problems, particularly irritability, aggression, self-harm, impulsivity, and hyperactivity and insomnia. It also helps manage the comorbidities like anxiety and depression. And by doing that, so by managing these things, what we also know is that it does improve social and global functioning. So there's definitely a role for medication because, as I sort of said, sometimes we get to a stage, to a crisis where you actually need to kind of manage and sell things before we can engage into meaningful activities or schooling and other forms of intervention. So there's definitely a role, but I think, again, we have to keep in mind the role is probably limited at this point. The antipsychotic medications, and this is one of the problems in psychiatry. We name medications, I think that's a misnomer when we call something antipsychotic. We know it works for psychosis, but when you really look at it, majority of people who are on antipsychotics does not have psychosis. And the same is true with depression. You call them antidepressants, but majority of people who are on antidepressants are not depressed. It's effective for a variety of conditions. So sometimes the name antipsychotics, and particularly when you're talking to sort of families and parents, they get a bit worried. You're going to start my child on something which is used to treat schizophrenia. That's a big concern that they have. But that's got the largest body of evidence, particularly in treating irritability. Risperidone and aripiprazole are 2 medications that are approved by FDA. There are a number of randomized, double-blind, placebo-controlled trials that actually have replicated the results. So the evidence behind risperidone and aripiprazole are quite clear, and it's been replicated across the world that it is effective while we are managing specific symptom profiles or specific behavioral issues. Other atypical antipsychotics have limited randomized trials. So there are trials, but they're the small or they are either open label studies. So there are evidence out there, but it probably does not reach the level of evidence that risperidone and aripiprazole has got. Haloperidol, a conventional antipsychotic medication, has been studied extensively. There are others that's out there, but haloperidol is the one in that group that's been investigated most. Risperidone, obviously sort of approved for treatment of ASD. I won't bore you with the receptors. Evidence for reducing irritability, self-injurious behavior, stereotypy, hyperactivity, and improving global functioning. When I say evidence, it's compared to placebo and statistically significant. Not effective in improving communication or social deficits, and it is superior to placebo when it comes to time to relapse. But obviously the bad bits about risperidone are the side effects, particularly weight gain, increased appetite, and hyperprolactinemia that you see. It's not, you do come across hyperprolactinemia now and again, but weight gain and metabolic side effects are one of the key issues. Aripiprazole, again approved for treatment, very similar to risperidone. The difference is the superiority in time to relapse compared to placebo is probably not as good as a risperidone. But on the other hand, weight gain is probably a lot better with aripiprazole. So metabolically, aripiprazole may be a better molecule. Drooling and extrapyramidal side effects are a concern. And it can be more expensive than risperidone, though. So there's always a cost factor, I guess. Olanzapine, one of the other atypical antipsychotics, the use is off-label, so it's not approved by FDA, and it's probably not approved by most. So it doesn't, TGA, which is the Australian equivalent of FDA, does not approve Olanzapine. It is used, and it is, there is evidence suggesting that it does improve global functioning. When it comes to other symptoms, there is a positive trend, but I don't think it sort of reaches statistical significance. But the biggest problem with olanzapine is weight gain, and that's a lot more compared to risperidone or aripiprazole. While the regular use of olanzapine should be balanced with that risk of metabolic syndrome, it does have a role in acute management. So when you look at a lot of health service protocols in managing acute behavioral distress in emergency departments, olanzapine sort of comes across as probably one of the accepted agents. So it probably does have a role in that acute management, but regular use, I think, has to be really cautious. Risperidone, one of the newer ones, again, it's off-label. So, and whenever it is off-label, it can be expensive because it's not as, I mean, again, I'm going back to the Australian context. PBS, which is one of the government agencies, subsidizes medications for us. But if it is off-label, it's a private script and makes it expensive. It is superior to placebo in improving global functioning. Now, that's a study which had 3 arms. So they had placebo at 20 milligram and 60 milligram arm. And they found that global functioning improved for the 20 milligram arm, but no much change in 60 milligram compared to placebo. So again, that probably needs to be replicated and kind of see why that's happened. Is that just that particular study? We probably need more to kind of clarify that. Drowsiness, akathisia, possible side effects, minimal weight gain, as we mentioned. But tolerability, that nausea and akathisia can be quite challenging with risperidone. Other typical antipsychotics, randomized double-blind sort of trials are lacking. They do have improvement in irritability for a small open-label study for quetiapine, but weight gain is an issue. But quetiapine is actually quite liberally used in this population, mostly to kind of manage sort of anxiety and insomnia at times. Really. There are small open-label studies for Risperidone, which again shows that it does improve irritability, less weight gain compared to the other agents. So there may be promise there, but again, needs more research, I guess. Haloperidol, most studied conventional antipsychotic, quite effective, but high frequency of dyskinesia and dose-related side effects. Sedation can be an issue. Antidepressants. Now, this is a group which is quite interesting. That you've got all these SSRIs. Unfortunately, in children, the efficacy or evidence has been a bit inconsistent. Even though in adults, you've got consistent benefits, particularly around managing restricted and repetitive behaviors. But in children, it's been inconsistent. The most studied is fluoxetine. There's one study which reported it to be effective, but there's another sort of unpublished study which Autism Speakers released, found it to be not effective compared to placebo. The other antidepressants are all pretty similar, except for Risperidone. Now, that's a partial serotonin receptor agonist, a slightly different mechanism of action. At low dose, that's around 2.5 milligram BD, it's sort of shown to be significant improvement in restricted behavior. But the same study noted that it didn't change the ADOS score much. But again, is that a problem with the study design? Is something that's being wondered. But it probably needs, it's promising, but probably needs more to kind of see what Risperidone does. Other antidepressants, again, sort of, when it comes to comorbidity in ASD, there's not many studies out there which have looked into managing anxiety or depression in that particular population. We've got sort of evidence for managing depression and anxiety in children in general, but not particularly in that sort of ASD population. Given the limited evidence, the recommendation has been considering fluoxetine as kind of your first-line option when we are managing anxiety or mood symptoms. But increased energy, impulsiveness, hyperactivity, they're all sort of side effects to be kept in mind. Anti-epileptics. Valproate, again, it's commonly used to manage, I guess, sort of this emotional dysregulation. which is kind of, I guess, the evidence comes from extrapolating its benefits in bipolar disorder, and we kind of extrapolated that into if it is beneficial there, it probably is beneficial in managing this sort of emotional dysfunction, which is probably, I think, quite patchy. There are a couple of small studies which sort of reported improvement in irritability. One study reported no change. So the evidence, again, is quite inconsistent. And side effects is, again, weight gain, rash, sedation. So probably maybe as a third or fourth line. Other anti-epileptic is very limited evidence out there, except for topiramate. Topiramate in combination with risperidone has showed improvement in irritability. So when compared to topiramate plus risperidone versus risperidone on its own compared to placebo, the topiramate risperidone arm had significant improvement for irritability and other behavior problems in ASD. So, stimulants and non-stimulants. I've just sort of clumped it all together. It was just mindful of time as well. ADHD is a frequently occurring comorbidity, and based on what study you looked at, the prevalence have sort of ranged from 37 to 85% of children with ASD seems to have a co-occurring diagnosis of ADHD. There are trials investigating methylphenidate, atomoxetine, clonidine, and guanfacine, particularly the sustained release tablet in this population. Interestingly, there doesn't seem to be a lot of research out there on dexamphetamine. But Dex has now got a new cousin, if you can sort of say that way. I mean, we've got the lisdexamphetamine, which has just been marketed in Australia, and I think that might bring more study into kind of looking at evidence for lisdexamphetamine in the population, but we don't have much at this stage. Methylphenidate, significant improvement in hyperactivity, and improvement has been maintained. So most of these studies where they have had the double-blind period, and then they've continued the study within kind of an open-label period, and the benefits have actually been maintained throughout that period. Methylphenidate extended release has also been sort of shown to be effective, particularly in managing that hyperactivity, academic performance, and maintaining that social functioning. So, but irritability, social withdrawal, emotional outbursts can all be challenging, particularly the coming off stimulant period, so the period from around 3 o'clock or 4 o'clock, when the coming off stimulants can be quite challenging. And it's, when you look at tolerability, 1 in 5 seems to be kind of dropping off the treatment arm because of possible side effects. So tolerability is an issue. Atomoxetine, a non-stimulant alternative. Again, placebo-controlled trials have found it to be quite effective in improving global functioning. They've also investigated that in combination with parent training, and no surprises there. The arm with atomoxetine and parent training did the best compared to atomoxetine on its own, placebo with parent training, and placebo on its own. So again, it's effective, and when combined with parent training, it's more effective. And I think that's again true for almost all medication. With atomoxetine, the open label period continued for 24 weeks post the double-blind period, and that the effects were maintained during that period of time as well. Clonidine and guanfacine. Clonidine is an alpha-2 adrenergic agonist. Improves measures of irritability, hyperactivity, and social relationship. So maybe there's some, maybe we're getting into some of the core symptoms there. It's generally well tolerated except for possible sedation and hypotension. So it used to be used as an antihypertensive in the past, and so sedation as well. It's because it's short-acting. If you really want a good coverage with clonidine, you end up having to kind of divide the dose throughout the day. So sedation can be an issue. Guanfacine sustained release, which is very similar to clonidine but selective in its action, has similar efficacy to clonidine but with less side effects, particularly sedation. And again, it can be a once-day dose as well, so much more convenient. Melatonin. Now, there's substantial evidence for sleep disturbance in ASD, and we also probably now know that the circadian rhythm probably is connected with brain development as well. So managing the circadian rhythm should sort of theoretically at least sort of help manage brain development, and it's got kind of a cycle. And melatonin has clearly shown evidence in improving not only total sleep, but also decreasing sleep latency and quality of sleep in some studies. In addition to that, it sort of then improves social communication, rigidity, and anxiety. So, I mean, again, it probably, if you are able to sleep well, you're probably going to be performing better the next day, I guess. The dose ranges have been a bit inconsistent, but most effective studies have actually documented around 5 milligram, which is probably on the higher side. So it's around 5 milligram from, if you're taking an average out of studies. Treatments in clinical trial. Now, this is not an exhaustive list. I just thought I'd sort of put things that are showing some promise. I'm quite optimistic about oxytocin. It's a neuropeptide produced in hypothalamus, one of the regions in the brain. As we all know, plays a key role in social bonding and attachment, and it probably has got potential to improve social reciprocity, facial emotion recognition, facial mimicry, and emotional perception and processing. So this is maybe one of those medications which may be able to get into the core symptoms of ASD. The current evidence is inconsistent, but it's trending towards more positive effects. Researchers have also wondered whether there is any difference in the age group that you use it. It looks like maybe younger the age, oxytocin seems to be more effective in a younger age group. So wait and watch, I guess. Mementin is actually an FDA-approved medication for severe to moderate Alzheimer's, and that's showing to be improvement in hyperactivity and inappropriate language. There's a large study which found that it's safe, but when it comes to its superiority to placebo, it's been inconsistent. So again, there's some positive. D-cycloserine, N-acetylcysteine, all similar. There are some positive trends, but we need more to make any recommendation. There's emerging data suggesting that glutamatergic agents in combination with risperidone may be effective. So whether these agents, if they're not working on their own, in combination with risperidone, it seems to be better than risperidone on its own. And if they are relatively safer, maybe a combination may help us actually reduce the dose of risperidone. A couple of other ones, clofen, again, a selective GABA agonist, improvement in global functioning in a 12-week study. Side effects included emotional lability, insomnia, anxiety, and GI side effects. Bumetanide, another GABA modulator. There's been improvement, but one of the issues with bumetanide is being the dose-dependent hypokalemia. So a compromised dose is around 1 milligram BD. So it's more, again, in sort of the clinical trial stages. So to conclude, we started with the conclusion, I think in some ways, to date, it's only risperidone and Abilify or aripiprazole. Both target irritability and has additional efficacy for hyperactivity and stereotypy. Metabolic side effects are concerning. There are several medications that would improve ADHD symptoms. Evidence for effectiveness of SSRIs are inconsistent. Risperidone shows promise, but needs further evidence. But like always, pharmacotherapy should be closely monitored for any side effects. And we should be sort of beware of sort of pitfalls of polypharmacy. For example, methylphenidate and clonidine. It's a combination that's commonly used, but with potential side effects of arrhythmias and sudden cardiac deaths. But you see a lot of children being prescribed this combination, and sometimes they do well. And in one of the peer groups, one of the pediatricians talked about, when you give something to go on a high, you need something to bring it down. So they kind of use the combination, but beware of that. Where possible, pharmacotherapy should be kind of only prescribed in conjunction with other therapy, but it's not always possible, as I sort of mentioned. When you go into kind of rural areas, and the availability of psychosocial interventions are quite limited, so it can be a challenge. But I think whenever we prescribe a psychotropic or a biological agent, I think we should always keep that in mind, that it has to be in the context of a global understanding of where this young person is, where the family is. Just wanted to finish with this last quote. I think I really like this quote. I mean, every child needs at least one person who's irrationally crazy about him or her. And I think when we talk to parents, sometimes your registrar comes back and says, that mom is crazy. And I think it's true. Parents are crazy and they're irrational about their children. And it's that craziness, that emotion of irrationality that we need to engage with. Thank you.